the guidelines say. So please note, this is not a talk on therapeutics. Each of the obesity drugs have dedicated sessions for them, so I'm not going to be repeating anything here. Let's look at obesity overall from a guideline point of view, and I have no conflict of interest to declare. This is a very interesting graph that I always show. It's from the NCD risk factor collaboration. And on the x-axis, it has prevalence of obesity, while on the y-axis, it has prevalence of diabetes over time. You'll see that the years are slowly increasing. Each circle there is a region of the world. And what it's showing is that across the globe, there are parallel increases in obesity and diabetes. So over time, the circles are becoming bigger, they're color-coded there, and the big one here in the brown is South Asia. So the big ones here, big increases happening in low and middle income countries, South Asia being at the epicenter of this. So this is something we know. But what is interesting is that in some developing countries, they have actually showed a slowing or reversal of obesity over the past 2 decades or so. This is not related to just drug use, but all kinds of policies and therapies that they have started. So it was reported, let's say, in children first, where the rate of increase in obesity in children first started coming down. These are all high-income countries that have achieved this through various programs, school programs, etc., diet programs, physical activity programs. And 10 years later, they show that the prevalence starts plateauing and then decreasing in adults as well. So that's a very good story for us, because in India and all of South Asia, we're on the upward trajectory of both diabetes and obesity. So I just talked about the ICMR INDIAB study a little while ago, and what we show here is the prevalence of obesity. So this is generalized obesity as defined as a BMI of more than 25, and just take a look at urban India. Red indicates 25% prevalence. I showed diabetes earlier, and at that time diabetes was 10. This is obesity, and we're showing at 25, and entire urban India has reported a prevalence of more than 25%. If you look at abdominal obesity, it's even more grim, because as we know, we have more abdominal obesity than we have generalized obesity. Almost the whole country is in red and orange. So these numbers are quite staggering here. You have 240 million people with generalized obesity and 350 million people with abdominal obesity in this country. So now let's look at the staging. This is the classical EOS staging that we use, and globally you know that the cutoff for obesity is 30, but in India and Asian Indians it is 25. So underweight is less than 18.5. Anything under that is lean diabetes. For normal, we have 18.5 to 22.9. Overweight starts at 23. Obesity starts at 25. Then beyond that is class 1 till 29.9, and beyond 30 is class 2. So this has been traditionally the way we look at it. But the EOSS also has stages 0 to 4, which take into account 3 separate things: the medical side of it, the mental side of it, and the functional capacity of an individual. So now let's look at it. So stage 0 has no sign of obesity-related factors, no physical symptoms, no psychological symptoms, or no functional limitations. So if none of these are there, they're at stage 0. Stage 1 is subclinical. So here we have hypertension. Now comorbidities are coming in: impaired fasting glucose or impaired glucose tolerance, mild elevation in liver enzymes, hypertension, borderline, mild disease, etc. So these are all the subclinical symptoms. Physical symptoms, here we have comorbidities that do not require any medical assistance. So you have a bit of dyspnea on exertion, but it doesn't require any medication. Occasional aches and pains, fatigue, stuff like that. And psychosocial symptoms, you have mild impairment of well-being, this feeling of not being well, but not really having any measurable outcome. So all of this is stage 1. If you move to stage 2, it becomes established disease, diabetes, hypertension, sleep apnea, PCOS, osteoarthritis, reflux. All of this has now moved into stage 2. The psychological symptoms, now you start having eating disorders, early depression, anxiety disorder, or a mixture of these. Functional disability, quality of life is beginning to get affected at this stage. In stage 3, we're talking about end organ damage, myocardial infarction, cardiac failure, diabetes complications, incapacitating osteoarthritis, psychological symptoms moving to major depression, suicide ideation, stuff like that. And here we're talking about impairment of quality of life and well-being. Last stage is severe, so this person is now bedridden, functional limitation, disabling psychological symptoms requiring hospitalization, and end-stage renal disease or end-stage diabetes complications. So this is how we have been staging it so far. But please note that all of this is based on a BMI classification. So what does BMI take into consideration? Your weight and your height. What it doesn't take into consideration is your body fat, which is essentially what obesity is. So while BMI is useful for identifying a certain group of individuals, it may not be the ideal situation when you're talking particularly about body fat, because it doesn't measure fat at all, it doesn't measure the distribution of this fat, and it cannot determine whether the fat is in excess or normal, or what it's doing. So for these reasons, using BMI, especially in Asian Indians, is a problem. Now, what happens when someone has a very high BMI? Okay, there is a possibility, there's also excess fat, but sometimes, rarely, you can find people who are athletes, who have a high muscle mass. They'll have higher BMIs, but need not have excess body fat. Now, that's one condition that is rare in a country like ours. But the other one, wherein your BMI is normal, but you may actually be harboring excess body fat in your belly or other places, that's the one I think is something that should not be missed and has cardiometabolic implications. So that is something that I'd now like to talk about in the INDIAB study. So we have looked, this paper has been accepted for publication in IJMR, and Dr. Muruganathan will be talking in detail about this later, but I'd just like to say two things here. The first is that we divided, for everybody, we were able to do the BMI as well as the waist circumference as an surrogate marker of visceral adiposity. So and also we had their lipids, and we had blood pressures, and we had glucoses. So we divided obesity into two types. The first is called metabolic obesity. So here they have two or more components of the metabolic syndrome, which is an increased waist circumference, or a fasting blood glucose of more than 100, a blood pressure of more than 130/85, or on hypertension medication, high triglyceride level more than 150, low HDL. For males and females, of course, you know the values. So any two of these is called as, it's a metabolic abnormality. So if someone had these, it was metabolically obese. Now, phenotypic obesity was divided based on BMI. So based on these two, so there's phenotypic obesity and there's metabolic obesity, based on these, we have four categories of people. One was called metabolically healthy non-obese. They're normals. They're normal BMI, normal waist circumference, right? So they are normals. Then you have the metabolically healthy obese. So no metabolic abnormality, but BMI-based obesity. Here's your athlete. This is the guy who we call MHO. The last guy is MU, which is metabolically obese. So obese by both ways, both the BMI and the waist circumference. So this is all okay. But I'd like to now draw your attention to that third category that's called MONO, metabolically obese, non-obese. Normal BMI has metabolic obesity. Now here is a problem, because this is a very highly prevalent condition in our country. If you take all of the conditions we just spoke about, the highest prevalence in our country is for mono. So people are thin, but they're harboring body fat. So is BMI picking them up? No, they're not. What does that mean? We are actually missing people with the complications of obesity because we are going by BMI. So in our problem, and especially this is more in rural areas compared to urban areas where they actually do have more body fat. So this particular feature we have now published in IJMR, and we are showing having mono is an independent risk for type 2 diabetes, for coronary artery disease, and chronic kidney disease. So this is a new feature that has just come and has gotten accepted for publication. We'll have more details about it in a later session by Dr. Muruganathan. We now also have a revision of guidelines. Obviously, we talked about the staging that was based on BMI. I established now that's perhaps not the best thing to do for India. So then what do? We now have a new staging that talks about two types of obesity. One is called clinical obesity, and the other is called preclinical obesity. Now, what are these? These are based on body fat. You cannot diagnose obesity without the presence of body fat. So that's the first point. You have to establish that. Clinical obesity is when you establish that the person has body fat, and then they also have signs and symptoms of organ dysfunction due to that fat. So it is metabolically harming the person, then it is called clinical obesity. So either it causes a reduced ability functionally, psychologically, or end organ damage. One of these you have to demonstrate, only then you call it clinical obesity, and please note that only clinical obesity requires treatment. What is all the rest? The rest is all preclinical obesity. So what do you have here? You have a person with excess body fat, but no other problems. They are fine psychologically, functionally, mentally, and they have no other comorbidity or end organ damage. So this is now being split, and those with preclinical obesity have higher risk for clinical obesity, cardiovascular disease, some cancers, and diabetes. But it does not require anything more than lifestyle modification. So that is the major change. First is obesity classification based on body fat, actually measuring that. 1. 2, preclinical obesity, no treatments. And therapeutics is only for clinical obesity. So these are the end organ damage that have been reported. Cardiovascular system, we do know there's cardiac failure, there's chronic fatigue, there's atrial fibrillation, pulmonary artery hypertension, DVTs, recurrent UTIs, musculoskeletal, all kinds of abnormalities, pains, hips, lymphedema, limitation of daily activity, anovulation, oligomenorrhea, PCOS, MASLD, we just talked about that. You have the metabolic abnormalities, which I just described just now, decreases in hypoventilation, breathlessness, wheezing, respiratory system, and of course CNS effects as well. So what is the approach to this? The first step, as I said before, is to establish excess body fat. How does one do that? If you're using BMI, you have to have at least one more measure of body size. So what are the measurements of body size that are acceptable? You need to have either a waist circumference, a waist to hip ratio, or a weight to height ratio. And these are the values for Asian Indians: waist circumference 90 and 80 for men and women, the waist hip ratio is 90 and 85, and waist to height ratio is more than 0.5 for everybody. So you need one, these are body size measurements. If you use BMI, you need at least one of this supporting that BMI measurement. Or what you can do is you can use two body size measurements. That is also acceptable. Or you can actually measure with DEXA or CT. So one of these ways of establishing body fat is the first one. Without the body fat, there's no obesity. Well, once you confirm obesity, you start taking a history because you have to establish end organ damage. So you ask the question, no signs, symptoms, no limitation, no treatment needed, preclinical obesity, lifestyle modification. If you're having signs and symptoms, you need to establish the signs and symptoms are from that obesity and not something independent. So obesity causing end organ damage, if you don't establish that, then again go back to preclinical obesity, lifestyle modification. If you establish that the obesity is causing osteoarthritis, end organ damage, target problem, cardiac failure, one of those, now you're talking about clinical obesity requiring therapeutics. So that's what this is about. So here's a quick assessment of how we will do this. So pay attention. Once you have, I'm going to ask you for the diagnosis, the old and the new. So excess body fat, no. Muscle mass is normal. Signs and symptoms, what's your diagnosis? What's your diagnosis? Old diagnosis, new diagnosis? Old diagnosis, no obesity. New diagnosis, no obesity, right? This person is normal. Next one, no excess body fat, muscle mass is normal, signs and symptoms are there, but BMI is now 28.8. Preclinical obesity, wrong. It is overweight by old diagnosis, but remember, there is no obesity here, there is no excess body fat. We started off by saying that the first step is demonstrating excess body fat. That is a no here. So it is not preclinical obesity. This is where people get stuck all the time. Okay? Now come to excess body fat is there. BMI is 28.8. Muscle mass has become low. Signs and symptoms, no. Now what do we have? Yes, overweight earlier, now called preclinical obesity. Yes, you've made the differentiation between the two. Don't go by BMI, go by the actual obesity one. Now, excess body fat, no. BMI is 32, yes. And signs and symptoms, no. There's no obesity, there's no body fat. However, I'd like to tell you that if the BMI is above 40, you can assume that the body fat is implied. Right? If it's that high, that's very rare in our situation. Now quickly, excess body fat, yes. Muscle mass low, no signs and symptoms. Preclinical, yes, 39. And 39 BMI, excess body fat, signs and symptoms, what are we talking about? Yeah? So here's what it is. Now what are the updates to the ADA standard of care? This has become very person-centric at the moment. Please use non-judgment language, don't say fat, obese, fatty. We do it a lot here. Okay, it's very judgmental. Please be sensitive and use person with obesity, etc. Additional measures of body fat distribution is necessary. I just talked about that. Annual monitoring of obesity-related anthropometry in order to look at progression from preclinical to clinical. People who have lost significant weight, start looking for sarcopenia. Dr. Ranjit mentioned that. We have a lot of treatments now, so sarcopenia is a problem. So continue obesity pharmacotherapy beyond weight loss goals, as now we are talking not just about the weight, but also about the body fat. So these are the things. There is a new standards of care coming from ADA just for overweight and obesity. We await that coming. I said before, I'm not going to talk about the drugs, but the ones we have in India are now Orlistat. Wegovy is outside just here in Mounjaro. That is called Zepbound outside, but Mounjaro here. And of course, liraglutide is not approved just for obesity in our country. We won't go too much into mechanism of action. There are separate sessions on each of these molecules for those of you who wish to know, so I'm not really going too much into this. But what I will do is I will talk about this one. So I'm not going into doses and all, but I'll talk about this one, because this is not something that you will see outside of this perhaps presentation. So far we've been talking about GLP-1. All the hype has been about GLP-1. There's injectable GLP-1, there's oral GLP-1, okay, there's all of these agents that we use, semaglutide being the new kid on the block. So we're talking about mono GLP-1 therapy, right? So that is what we've been talking so far. Then we now talk about tirzepatide, Mounjaro, which is GIP and GLP-1 agonist together, dual agonist. So you have monoagonist, which are the molecules here. You have the dual agonist, which is tirzepatide. You have triple agonists, like retatrutide. So here you have GIP, GLP, and glucagon. So you have triple agonists that are coming. The ADA declares that there are GLP and glucagon ones, so these are called mazdutide and survodutide. This is coming, not yet come to market. But an interesting one is another oral GLP-1. Okay, so this has reached phase 3 clinical trials. So it's orforglipron. This is something, it's an oral GLP-1 like our Ribelsis. It's similar to this. It's another small molecule, GLP-1. So this is promising. These are promising. We already know about CagriSema. So this is an amylin, cagrilintide and semaglutide together are called CagriSema. So all of these combinations are coming. But the one that I wanted to draw attention to is maritide. So this is a combination of GIP and GLP, but one is a GLP agonist. The GIP is an antagonist. So this is the first of its kind, where GIP is the antagonist and GLP is the agonist. A combination of this is called maritide, and that is also now in the pipeline. Right, so I'll conclude by saying that the prevalence of obesity is high. In India, over 43% of the population are metabolically unhealthy with normal BMI. We need to go beyond BMI, establish fat as a clinical entity. Adiposity has preclinical and clinical. Only clinical requires treatment. Organ dysfunction is what determines whether or not treatment is there. So we have newer definitions coming for obesity management. Thank you so much.